did you want to give any more of an introduction? I know you provided Tim with your background, and that was awesome. So grateful to have such a talent with us tonight.
Thank you very much, guys, for inviting me. It's an honor to be here. It's been a while since we got together. I know way back at Beaumont Hospital.
Right.
We had a couple of events there. Well, today probably it's going to take us about 30 minutes, 45 minutes to go over what's going on these days with facial pain and trigeminal neuralgia. So if you have any questions, for later, I will be more than happy to entertain questions. But I'll be talking more about neuralgia and neuropathic pain. Let me see. Okay.
Do you prefer the questions in a chat box, or do you want people to hold the questions?
If somebody like one of you guys can pick up the questions.
Yeah, I'll be happy to do that.
And then you can ask me on the behalf of all of you, and then we'll be
perfect. Okay, perfect.
And then we can share everything, I guess.
Perfect. Thank you.
So we're gonna do some general overview for the orofacial pain. Differentiate between neuralgia and neuropathic, emphasizing on history taking, because we know with facial pain, history taking is very important.
Mm-hmm.
And also to distinguish between diagnosis of trigeminal neuropathy and some pitfalls of diagnosis of systemic autoimmune trigeminal neuropathy, because now there is some directions, some of the autoimmune diseases may cause trigeminal neuropathy. And then we
really,
yeah, that's I heard this neurologist, interesting cases. There is a lack of a standard treatment strategy in the treatment of autoimmune related orofacial pain. So I'll brief you with everything, and then we'll go from there. So as you know, and everybody knows, facial pain patients with chronic pain patients or neuropathic pain patients, trigeminal neuralgia patients go through a lot of trips to doctors, different doctors. They may start with their dentist or their physician. They end up with the orofacial pain dentist or orofacial pain surgeon, ENT, neurosurgeon, ophthalmologist, psychiatrist, psychologist, anesthesiologist. So all these visits, I'm sure, cause more stress, more pressure on the patients. We get confused, patients get confused to they should consult with, and when they develop facial pain. So do they go to their dentist? Do they go to their physicians? And then depends on who they are seeing first and their comfort level with the referral. If they know of somebody who's, his practice or her practice is for facial pain or neuralgia, or because not all neurologists, treat neuralgia as well. And so we need to choose the right specialist to refer our patients, or to refer, I guess, make the right referrals. Now, also imaging. When we get the patient, we have to choose the right image, you need really to do also good neuroradiologist to evaluate the MRI or CT scan they are taking. So what kind of image we need, and who's reading it, and how to read it, and the comfort level of reading it. I know most hospitals, most imaging centers have neuroradiologists, and things are getting better with the diagnosis and the imaging, and I heard that MRIs are getting more sophisticated, and they have really good quality imaging. We know in 2018, I think the International Association of the Study of Headache came with their classifications of orofacial pain. And we see that cranial neuralgia and facial pain became part of the headaches classifications. And the American Academy of Orofacial Pain and Orofacial Pain segment from the International Association of the Study of Headache of Pain, we came up with our own classifications as well. So the trigeminal neuralgia has two kinds: the classical, the secondary, or three parts, and the idiopathic trigeminal neuralgia. The classical has neuralgia that purely paroxysmal. So patient comes with these symptoms: the electrical shock and pain, periodic, and may change to be more continuous pain as well. That's not always will be paroxysmal. This is really the classic trigeminal neuralgia. The secondary trigeminal neuralgia, which really is part of secondary to a disease like multiple sclerosis or lesion tumor in the brain or close to the trigeminal nerve, or it could be to other cause. What other cause? God knows. I don't like when they say other cause. Like what? The idiopathic trigeminal neuralgia is also purely paroxysmal. There is no cause for it, and will become more concomitant with continuous pain. So the same thing as classical neuralgia. And so I prefer to have them only two classifications, the classical and the secondary. The neuropathic pain is known for as a result of some disease like herpes zoster or post-herpetic neuralgia. Trauma sometimes may cause neuropathic pain. We know some dental procedures, or 10% of our dental patients may develop neuropathic pain post-extraction or post-periodontal surgeries. So these are not uncommon. Also, there are some other other disorders may cause neuropathic pain. So again, we need to know what other causes may cause neuropathic pain. So in general, the trigeminal neuralgia is a disorder characterized by recurrent unilateral by brief electrical shock-like pains, abrupt the onset of and termination. So it comes and goes without a reason. It's mostly really one branch of the trigeminal nerve, very rarely two branches, and unusual to happen in the first branch of the trigeminal neuralgia, the trigeminal nerve. If it's a red flag if you see it in the V1 and in the optical nerve. So also it may develop without apparent cause to be a result of another diagnosed disorders. Additionally, there may be concomitant with continuous pain and moderate intensity. So not always we see electrical shock and pain, and sometimes it may develop more continuous pain. We look for a few things when we evaluate trigeminal neuralgia patients. They have to have lasting pain from second to couple of minutes. It's severe in intensity, and it's like electrical shock pain, shooting, stabbing pain, and could be really by noxious stimulation. That means really you don't have to apply hard pressure to cause the pain. Light touch, brushing teeth, wash your face, it may develop these kind of symptoms. So trigeminal neuralgia must be established clinically by investigation and by identifying the cause of the trigeminal neuralgia. We talk about and you know about the neurovascular compression. It is very known now, and I see more neurosurgeons don't do surgeries if the artery or the vein is intact or in contact with the root. If they only do the surgeries when there is a compression and this displacement of the artery. So we have to look at the neurovascular compression, the contact, and make sure really there is a compression by the artery. So the nerve root atrophy and or displacement due to neurovascular compressions are important to associate with the pain and the trigeminal symptoms. So if you take a look at this picture here, this is the proximity of the vascular system or the nerve of the artery or the vein, and this is the cross section here in the upper left corner. So it's a little bit far away, but it's not really close to it. And here is in contact with it, but it's not causing indentation in the nerve. In the lower left corner, there is a compression. This is really where the neurosurgeon now going toward making more of the surgeries. It's recommended. And depends on the pressure, it may cause distortion of the nerve and it pushes away. And also this is mostly highly recommended for surgery. Now, with the neurovascular compression and MRI, they found that 17% of the general population shows neurovascular contact of the trigeminal nerve. This is the population, not patients. And they found that the incidence of trigeminal neuralgia is about 0.01%, in some studies 0.3%. In these patients, that 99.94% of the individual with neurovascular contacts, they don't have trigeminal neuralgia symptoms. So not everyone with the contact, if they find these incidental findings sometimes, or if the patients have pain and they do MRI and they found there is a contact, but 99.94% of these patients or these people don't have symptoms. So the trigeminal neuralgia should not be diagnosed based on a presence of neurovascular contact and MRI. So we have to take the history from the patients because they found that they did autopsy studies and revealed that some degree of contact between trigeminal nerve and blood vessels in 90 to 100% of the patients with trigeminal neuralgia, but also in 16 to 58% of patients without trigeminal neuralgia. So there's a big difference. Patients who have trigeminal neuralgia, the contact between the vascular and the nerve is high. But the patients who don't have the trigeminal neuralgia symptoms, it was between 16 and 58. The etiology of trigeminal neuralgia, we know Janetta in 1967 who defined it and he's the father of the neurovascular decompression, the microvascular decompression. So the cause of trigeminal neuralgia is caused by compressions, and usually within few millimeters from the entry of the root entry of the pond. And this is, if you take a picture here, this is the area where the usually we see that most of the problems. It's very important to us, to me as orofacial pain dentist, and to neurologists or people who really work with chronic pain patients, to take the history. 80% of our diagnosis depend on history taking. Physical examination is about 10% and investigation another 10%. Because we can't depend only on the MRI to do the diagnosis. So why do we do so many investigations when investigation means testing? The diagnosis of most of the facial pain is based on careful history and examination. As again, I spend probably 30 to 40 minutes or 45 minutes taking history from patients, depends on the severity of their case or the complexity of their case. The only thing we do too many investigations for a couple of reasons. Defensive medicine, so because of increase of litigations, we need to protect ourselves from litigations. Sometimes lots of confidence in our ability to extract meaningful information and history from the patients and doing the examination. So these are really two things. And the last thing is not enough time to take history from the patients. Because like if you work in a hospital or if you work in an institution, they want you to see more patients. They want you to, I guess, bottom line, make money to the hospital or the institution. So this takes more, they wanted to see more patients, so it takes a little bit more time. And so you don't have to spend too much time, or you can't spend too much time with the patient or the patients when they come for the visits. Or the patients are seen by incorrect provider. So they go to the wrong provider and they end up with the wrong diagnosis. The history taken from the patients, we look at different things. We have a list, like the pilot, when they fly the plane, they still have their checklist and they go through it. And the same thing with us. We look at the onset of the symptoms, the age, is it acute or gradual? The location, is it unilateral on one side or bilateral, both sides? And we go through the trigeminal distribution or trigeminal nerve distribution. The duration, seconds, minutes, hours, or constant or continuous pain. Also, the time of the day, in the morning, in the evening, at night when sleep. The quality of pain is very important. Is it jabbing versus non-jabbing pain? And jabbing means electrical shock and pain, or if it's dull pain. What causes the pain to take place? What aggravates the pain, and what triggers it, and what alleviates the pain? So we have to know what caused the pain to get worse or what triggers it. And what makes it better, medications, applying pressure, ice, heat, whatever we can extract the information from the patients. Taking the medical history, taking the dental history about their dental visits, their dental surgeries, the same thing with the medical histories. Social history is very important for many reasons about their social life, drinking habits, smoking, about social activities, and if whatever reasons we like to know that. Also, if there is any association with migraine headaches or other headaches or sinus headaches. If I'm talking too fast, let me know, guys, because I have tendency to talk fast. Red flags, and these are really important for you guys and for other for dentists and physicians. If the patient comes, or your neighbor or your friend or whatever tells you, like, I have trigeminal neuralgia pain, and if they are really younger than 50, usually 40, this is a red flag, because patients under 50 or 40, usually 40, don't get trigeminal neuralgia. So we have to look for different cause of the trigeminal neuralgia. If the absence of continuous trigger, like light touch, so this should, if there is no trigger by light touch, then it's a red flag as well. Abnormal oral or dental or ear examination, presence of or other neurological symptoms, difficulties walking, dizziness, vomiting, or high fever as well. So there is abnormal neurological examination. If the symptoms are on both sides, also it's a red flag, because we know that trigeminal neuralgia is one-sided problems. Visual changes, neuritis, optical neuritis, because this we find it more with MS patients. Or if we have difficulty achieving pain control, if we diagnose the patient with trigeminal neuralgia and we are treating the patient with the protocol that everybody knows, then if the patient's not getting better, that means really we have to think again about treatment protocol. Poor response to carbamazepine, like Tegretol. We know carbamazepine is the treatment of choice for trigeminal neuralgia. If the patient has numbness and burning sensation in the face, or if the pain lasted more than 2 minutes, if the pain is outside the trigeminal distribution. Some patients may tell you, I have the pain extended to my neck or goes up to my behind my ear. These are really not trigeminal neuralgia symptoms. And the other red flag, as mentioned earlier, V1, the eye branch, ophthalmic branch is if it's only there is something wrong beside trigeminal neuralgia. Or if the presence of photophobia and phonophobia, so these sensitivity to light or noise. Or there is throbbing or stabbing pain. Or if there is any hormonal changes, hormonal related issues, and there is hearing loss or dizziness or tinnitus as well. We have to really be very careful. So these are really the symptoms. If somebody, talking about it and they are been diagnosed with trigeminal neuralgia, we have to be careful and take further evaluation for their case. So the secondary trigeminal neuralgia, we talked about multiple sclerosis or tumors, lesions in the brain causes pressure on the trigeminal nerve, or other cause could be other problems. So we have a patient of 85 years old with right facial pain, which started approximately 6 months ago. This is some histories. Pain is located on the right side, lower jaw area, B3. Described the pain as jabbing and jolting electrical-like pain. He denies any numbness or tingling in the face. He stated that he thinks the pain is triggered by chewing. So it's not continuous trigger, so it's not really light touch. So this we have to be careful about it. As we said earlier, patients should have pain on light touch. And this is really what caused the pain here. There is a tumor, schwannoma, on the right side. So this like for us as physicians or pain practitioners, we should really look at these cases carefully. So we have to look at the temporal pattern of pain, associated symptoms, smell sensitivity, and this is really for symptoms related to headaches and facial pain as well. Cranial autonomic symptoms, lacrimation, nasal congestion. This really slide should not be here anyhow. Talking about food, but you know these symptoms is headache symptoms, and this maybe get confused with facial pain. So that's really one thing for the examiner should be careful, and for the patients to distinguish between these kind of headaches, pain, migraine headaches, and trigeminal neuralgia. So we have to distinguish between the neuralgia, neuropathy, where it is and how the patient is feeling it. Neuralgia defined as a neurological pain have a paroxysmal quality, which is typically maximum at onset and is often described as lancinating, shocking pain, jabbing pain. The neuropathy pain disease is dysfunction of one or more peripheral nerve, typically causing numbness, tingling, or weakness. So these are the difference between the classical trigeminal neuralgia and the neuropathic pain. Neuropathic pain is the disease of the nerve. It's not really caused by anything else. So the differential diagnosis for trigeminal neuropathy, there is a central demyelinations disorder, multiple sclerosis, herpes zoster, post-herpetic neuralgia, trauma to the trigeminal nerve or to the nerve or peripheral nerve, which may cause anesthesia dolorosa, which really pain with numbness and burning sensation. There is atrophy, trigeminal atrophy syndrome after stroke or ischemic changes in the brain. And there is a space occupying lesion, that means there is a tumor. And as I said earlier, there is some direction now for autoimmune disorders. I heard this neurologist talking about this, and he presented some cases. And I think one of the cases here is his. 70-year-old right-handed female came to neurology department. She notes ongoing pain across the lower jaw on the left side, this left side. Over a year ago, and she had some dental procedures. About a year ago, she developed an ongoing pain in the lower incisor area, in this area here, and had root canal twice without relief and extracted the teeth. She reports that afterwards she had developed aching of the teeth or the tooth adjacent to the tooth, the root canal, and that's really a problem. We see it all the time. The pain moves from one tooth to the adjacent tooth. So she did have dental implant and noted similar ongoing achiness across the left chin adjacent to her implant, and had a root canal without benefits. Her most recent procedure was about 2 months ago, and then her endodontist told her that no more surgery was needed. She has been seen by one of the orofacial pain specialists. She was diagnosed with neuralgia, and she stated that a trial injection of local anesthetic give her some good relief for a while. She started also like gabapentin and was maintained for 600 milligrams 4 times daily. She has significantly reduced the pain, but really the side effect of the medication caused her to be dizzy a little bit and tired. And she has no longer is awakening due to facial pain. So these are this patient history. The imaging, we took imaging and they found an MRI, there is a lesion on the right side, an auditory canal, some 3 by 4 millimeter suggested acoustic schwannoma. So these are really more incidental findings. This is to the visit. Here, pain level was very unpredictable at 8 out of 10, which point her to has to rest. So that's the pain on the left side. She lost no jabbing or electrical component, no specific triggers such as chewing, swallowing, or bruise. There is no specific time of the day where the pain is worst. She denies any numbness and swallowing. She has tried anti-inflammatory medications with some relief. She has not been tried with amitriptyline. There was talk about that amitriptyline like Elavil and other tricyclic or Cymbalta. She does not know that in the past she did well with Cymbalta or treated to treat bladder pain. She has been searched a variety of options, surgical included, and present now for neurological assessment. So this is, we know that with regional neuralgia should be jabbing pain. So there is no jabbing pain for her and no electrical component. So with these cases, do we agree with diagnosis of trigeminal neuralgia or we don't agree? And do we suggest to do surgery, neurosurgery, referral or not? These are really thoughts everyone or in the practice or facial pain or pain or neurology, think about it. So we have to assess the patients. We have to make sure to take the right decision. Referral to the neurosurgery for the schwannoma is very important. Putting the patients on medication also important. So we have to make sure really that the plan is discussed with the patient, with the treating doctors as well. So the bottom line is the patient has peripheral trigeminal neuropathy, and there is no reason for microvascular decompression, and the referral to the neurosurgeon is good. So usually, as I said, we try to make sure really the patient, we are not missing any problems with the patient, so we refer him to neurosurgeon. And I know neurosurgeons now, they are really trying to do less surgeries if there is no real compression and displacement of the nerve. Again, this case too, the patient almost similar histories, but there is never had electrical shock and pain. So we have to evaluate the patient. I'll go through the cases very quickly. Also, the patient seen neurologist for headaches and started Cymbalta. Again, she was placed. She was seen by multiple people. Mostly start with the dental problems. She has it for 40 years when she was 40 years old. Also, the duration, it's a constant pain. Never had short-lasting pain, so all of it really long pain. No continuous triggers. So these are really important things we have to look for it. Looking at the patients, evaluate their pain. Is the patient with significant pain in tooth 22 and 25, that's the lower anterior teeth. Pain is constant from beginning without any neurological quality. Therefore, excuse me 1 second. my office manager. So all these really explain that the patient does not have trigeminal neuralgia, and we should avoid any unnecessary surgery. Looking at this case, we see there is dry mouth, there is some underlying autoimmune diseases, children. They did steroid study trial for a short period of time. Patient did okay with it. Then they did remove the question was to small mass in the right side, the schwannoma, which really incidental finding. There's no symptoms. Patient has no symptoms with it, so they left it alone. So there is increase in steroid that help the patients to help with the symptoms, with the Sjogren's symptoms. So I'm a dentist, and she had good quality response to heat. So what is the diagnosis? That's what we come to our final conclusion after knowing all these symptoms, and the patient was placed on another course of steroid, and so the improvement with the steroid is not really always good, and you can put the patients for long term on steroid. So these are really comes to our mind when we see these patients. So with the neuropathic characteristics, it's hyperesthesia, hyperalgesia, allodynia. So these are symptoms where patients feel more sensitivity to pain. Light touch causes more pain. Underlying, we should look at underlying pathological changes. It can be localized or can be really in the trigeminal pathways, including the trigeminal nerve or the ganglion or the roots. The nuclei, also look for some inflammatory or infection. Painful trigeminal neuropathy caused by herpes zoster, demyelination, multiple sclerosis, tumors, vascular diseases, trauma, and lately they are talking about really autoimmune neuropathy. Let me go past this to go over a couple of things, last couple of slides. So with facial pain, we have the unilateral continuous orofacial pain. So the pain is continuous pain. When patients come with this kind of pain, we have to look at first if the patient has post-herpetic neuralgia, post-traumatic trigeminal neuralgia pain, anesthesia dolorosa, persistent dentoalveolar pain, atypical odontalgia, or deferred pain. If the patient does not have continuous pain, could be trigeminal, could be TMJ disorders or muscles pain. Also, we look at if the patient has unilateral continuous orofacial pain, if there is post-stroke pain or giant cell arteritis. I'm not sure if you are familiar with giant cell arteritis. It's the temporal artery gets very inflamed and very painful and very sometimes cause blindness, or could be really chronic migraine or pain cancer. Again, going back to if the pain is not continuous, could be burning mouth syndrome or persistent idiopathic facial pain. Now, if the pain is episodic, mean comes and goes, it could be trigeminal neuralgia classical, could be trigeminal neuralgia symptomatic, trigeminal neuralgia concomitant with pain type 2, or glossopharyngeal neuralgia. And we see it often all the above with some patients, like glossopharyngeal, or we see it less often than really trigeminal neuralgia, let's put it this way. Or it could be trigeminal autonomic cephalalgia, like headache. That's really, we should be also aware of it. And usually patients with trigeminal autonomic cephalalgia, the headaches with tearing, runny nose, redness in the eye or in the face, or could be episodic migraine. If the pain is not episodic, unilateral or facial pain, could be tension type headaches or medication overuse headaches. Now, let's take home message. Not all facial pain are trigeminal neuralgia. It must be trigeminal plus neuralgia. There are no tests for trigeminal neuralgia, or for the matter, most causes of facial pain is history taking. Is the main key for diagnosis. That's really very important to us. As I said, we can't. If I'm teaching my student at the university at the St. Joseph Hospital, and I told them history is very important. You should really take history. Then the wrong diagnosis can be lead to the wrong treatment, unnecessary brain surgery. We really should not harm the patients. Facial pain could be presentation of primary headaches, mostly migraine, or systemic inflammatory disorders, mostly autoimmune. As I said, there is this neurologist out of, I think, North Carolina, Chapel Hill. He's doing some good evaluation for some of his patients. The cause of their neuropathic pain is autoimmune diseases. Now, I'd like to thank you all. I don't know if you have any questions. I'll entertain your questions. Hopefully, mostly related to dental neuropathic pain or anything.
I don't see any questions through the chat box. Does anybody have questions they'd like to share? Maybe you could stop sharing your screen, Dr. Kaspo, so that we could see hands raised. Thank you so much. That was wonderful.
Thank you. Thank you.
Does anybody have any questions they'd like to ask?
Well, I would. This is Linda Alling. I'm having progressive symptoms, and now I have a fourth cranial palsy, so I have double vision, and my visual fields do not converge. I have a left tongue deviation. I have total lack of sensation inside the left side of my mouth. Difficulty even feeling if I start swallowing left side, and I have no tears and no I can't make tears, and I can't cry out of my left eye, my affected side. Everything has seemed to progress, and this is following 2 microvascular decompressions, 2 rhizotomies, and CyberKnife. It's just, I seem to do better after the decompression, and I have just deteriorated over the last, maybe the last 6 months. And it's just stressful. They want to do physical therapy for me on my face. So I'm not sure what that's going to involve, but I've tried everything. I've tried lidocaine infusions, injections into my face. Food drops out of the left side of my mouth. I mean, it's been very miserable, very miserable. I seem like I'm worse than when I was first diagnosed, you know?
You know, that's the problem. Multiple surgeries is not always really good things, you know what I mean? And unfortunately, we, you know, as patients, you don't know, and you always seek for help, cry for relief, and sometimes, you know, physicians, surgeons do surgeries for hoping that they can alleviate the pain, and unfortunately, not all of them, and I don't want to know, not all of them really understand chronic pain. You know what I mean? They like to try to alleviate the pain. But when patients develop, when you do more surgeries, we know it in general, you cause more harm.
Mhm.
I have few patients, they went to multiple surgeries. Do you think they are better? Not really.
Mm-mm. Yeah. Yeah, I question now if I have anesthesia dolorosa,
Yeah,
because I do have pain and numbness. But I think I got much worse after the cyber knife. You know, I really do.
Yeah. When was the cyberknife, Linda?
It was last summer.
Okay.
Mhm.
Oh, I'm sorry you're going through so much. That's terrible.
I know it's very hard.
Hindsight, doctor, but we had mentioned to Linda when she came to us, I was advised, a year or two ago, through people in Midland, that the IRSA, in fact, I talked to them direct, had recommended never using the CyberKnife for trigeminal neuralgia because it's not as accurate as the Gamma knife if you're going to radial surgery.
Yeah.
But that's all hindsight for Linda.
Mhm.
Wasn't able to help her. Do you recommend opiates at all, doctor?
Unfortunately, I don't. Or fortunately,
Yeah.
I really don't. We don't believe with the chronic pain opioids help. It doesn't mean really does not have role in patient care. If somebody not abusing the medication, the opioids, and taking it for pain, I really have no problems with that. You know, like in my practice, I have a couple of patients, I put them on Valium. They don't abuse it. I give them Valium, one script 30 tablets, last them for 3 months, 4 months. So I'm not concerned about their abuse. And now with the EMRs and you can watch patients' prescriptions, so what they are taking, what they are not taking. So this really, you can monitor them if they are taking other scripts from other doctors.
Mm-hmm.
Yeah, I've worked with hundreds around the world that have found relief with opiates. But to your point, the way the pendulum's swinging, it's gone way in the negative direction because of people using them illegally. So that's why many physicians have stopped prescribing them. So I don't question you for not doing it. I understand the current climate, but we do have many that have found relief with them only as a last resort. And sometimes,
we know,
yeah.
I'm sorry to cut you off. We know the patient who has the chronic pain and the pain, and we know the patients who are coming for drugs. You know what I mean? Unfortunately, you know, some practices are established to deal with patients and prescribe opioids. Some not. I'm not personally. I don't feel comfortable. You have to be trained. You have to be, you know, do random testing. You know, it's just sometimes you have to be careful what you do.
No, I understand.
We have a question from Donna about medical marijuana. What do you think about medical marijuana for chronic facial pain?
I always say whatever helps the patient, you know, I'm okay with that. As long as really you don't over abuse it, or you know, I have few patients, they are on medical marijuana, they like it. They like the effects and that it's helping their pain, which is okay. That's good. You know, I actually there is now some kind of courses for dentists to learn how to do medical marijuana for patients.
Right.
So,
is there a variety that works better for facial pain?
I really don't know much about it.
Okay.
I should try it, I guess.
We have 2 hands up, Kim and Susan. So I don't know who came first.
Susan came first, sweetheart.
Okay, Susan, go ahead.
Unmute yourself, Susan. Unmute yourself.
I don't think
I
have to tell her.
I just sent her.
Everybody poke their ear.
Unmute.
There we go.
No.
There we go. No, not yet.
No. She's trying to fix the camera. Unmute yourself.
Send her
I
another
can't
note.
hear you. Poor
I-
thing.
I've clicked on it 3 times.
Wait,
Oh.
the chat.
Here we go. Here we
There we
go.
go.
Oh, good
Do
job.
you think that a dental injection could cause trigeminal neuropathy?
I never heard of it. I never heard of it, but
You're hearing of it now.
where was the injection?
I had a gum graft surgery to take a graft off the roof of my mouth and put it on the side of my gums
Uh-huh.
to correct
Bone recession, gum
gums.
recession.
Yes.
Well, probably the neuropathic pain came not from the injection, from the surgery itself.
Yes.
So it's not really unusual. Yeah, we see that.
So you think like sewing the cutting the graft or sewing it onto my gums could
Could be
cause
the
it?
surgery. It could be multiple causes: the cut, the sewing, the bone. It could be the combination. Sometimes, as I said, teeth cleaning patient may develop a neuropathic pain.
Mm.
Not necessarily, major surgery. Sometimes very minor surgery may cause it.
So was there a precursor? Did I have something
I don't know. I sometimes maybe some pre-existing condition, genetics could be anything else. You know what I mean? Your system could be, the nervous system is very sensitive. And
What
it
helps
could
your
be-
pain, Susan?
nothing?
Have you tried that lidocaine, that viscous lidocaine that dentists
Yes.
use? That
Yes,
doesn't help at all?
I have a what do you call it, a tray
Bottle of
or
it.
whatever, and I put
Yeah.
put some of the lidocaine in my mouth at night, and that's the only way I can sleep. But I've
Oh.
tried, I don't know, 50 medications. I
Oh
bet
my
if I
word.
added them all up, everything, gabapentin, carbamazepine, Tegretol, blah blah blah.
Susan,
Oh.
Nothing.
Susan, give me an email separate to me and let me talk with you about something.
Okay, I
Okay.
know your friend Alan. He's the one that introduced me to your
Or are you
Your
Susan
group.
Mills?
Pardon me?
Are you Susan Mills
Yes.
in California?
Oh, very good.
In California.
Yes.
Yeah.
Yes.
Thank you.
Yes.
I'm glad you could
Yeah.
join us, Susan.
Thank
Kim,
you
what?
so much.
Yeah, you're welcome. Kim, what would you like to ask Dr. Kaspo?
Hi, everyone. Thanks for
Hi.
allowing me this moment. Doctor, I was just with my primary care physician, headed to my neurologist next month, and she simply asked me if I thought gabapentin was still being effective for me. And I said, I don't know anymore, and I think it could be weather related. Like, there doesn't seem to be any pain relief for me in the cold at all. And she asked me if I had ever tried Elavil.
Mhm.
Use the science word for it. What's the difference between the two medicines, if any?
Elavil is antidepressant medication. It's tricyclic antidepressant medication, and it works very well for chronic pain. They don't use it for depression anymore. We use it for pain, for sleep, and for headaches. The gabapentin or Neurontin is anti-seizure medication. We use combination a lot, these two combinations.
Oh, did I
both
say
of them are really
gabapentin?
good.
I thought I said Cymbalta versus Elavil.
No, Cymbalta is like different kind of okay. There are two. The tricyclic antidepressant medication is very old family of antidepressant. They don't use them anymore. Now they use the SSRI and the NSRI. The problem is with the new generation antidepressant medications, cause, especially the SRI, insomnia and teeth clenching. The same thing with the Cymbalta and the other ones. They are good medication to use, but you should really use it in the morning. Cymbalta is good medication for chronic pain, but Elavil usually helps the patient sleep better So that's why giving it at night, 2 to 3 hours before bedtime is good in combination with Nuraten or gabapentin.
Thank you.
No problem.
Next up is Nicole. She has a question about Sjogren's on chat. Go ahead, Nicole.
Hi, can you guys hear me?
You sure can. Thanks for asking a question. Go ahead.
So my pain started after a root canal procedure on my upper tooth. And since then, I've developed severe dry mouth, burning, and like a metallic taste. And I go to my dentist and he's telling me that it's not dental related. What could be causing this, like the metallic taste and the dry mouth and the burning, and it's unilateral on one side?
Well, usually like sometimes burning mouth syndrome, maybe combination with different things. Did they do any biopsy of the salivary glands? The
No,
small one and the lip?
I don't even know where to go. I mean, I've been to my PCP, I've been to a couple neurologists. They just keep telling me atypical facial pain, but it's not responding to any of the medications. I've tried Tegretol, I've tried amitriptyline, all of them, and the metallic taste is just on one side of the mouth.
I really don't know, but if you want, I can give you this neurologist, So I need, like, for the autoimmune disease, what kind of test ANA came back? But ANA is not enough really to diagnose for autoimmune diseases.
Mm-hmm.
There are more long panel of testing for autoimmune disease.
I'd love to know the name of that neurologist in North Carolina.
I'll send it to Tim, and he will.
That'd be great. That would be great. Thank you. That's very interesting. And Donna Duff is next with a question about shingles. Go ahead, Donna.
So I was wondering, let's say you had shingles in the past. Like I had it twice on the side of my face as a teenager, and then root canals later on that we thought damaged the nerve. Could the root canal damage wake up shingles pain?
I don't think so, but I don't know. I'm not sure really. Is it the same area you said?
Yeah, I mean, I had the shingles in the same area, and then I didn't have pain for years until that tooth got root.
Could be. Sometimes we there's some reports of shingle in the around the teeth, around the internally.
That makes sense, Donna. Did you take the Valtrex 3 times a day for a week to 10 days when you had that?
No, because it was back when my first episode was at 14 years old.
And they didn't give you Valtrex or something
I don't even
similar?
know if they had it back then.
Yeah, they did.
Did they?
You're not that old. What do you mean? You're not a dinosaur.
I'm a dinosaur.
No.
That would be like, 30 some years ago when
Have you gotten the Shingrix shot?
I did in my late 40s.
Okay, but the new one, the Shingrix, is the newer one. That's a lot stronger.
No, I don't think I got that one.
You need to get that one. Everybody should get that one that has TN. You do not want to get that. It can get in your eye and in your ear.
Yeah. I get breakouts in my left eye all the time too.
Well, you need to get the Shingrix then. Don't you think, Dr. Kaspo?
I think it's very important. Yeah, absolutely.
Yeah.
Absolutely.
Yeah, I know when I had it, they thought it was coming in the eye and the ear, and my neurologist flipped out and had special imaging done, sent me to an ENT, and then kept me on really high-powered Valtrex for 10 days or something, like 1,000 milligrams a day.
We had one man in our meetings that had shingles in the face and was causing his TN. I think it's rare, but they related it to that. Was that Nicole that talked about the root canal?
No, Donna.
No,
No, somebody earlier.
Oh,
Yes.
yeah.
Mine started after a root canal. Mm-hmm.
And Nicole, would you write me separately? That's my history. Maybe I can help you.
Yes, can you
guys,
put your
Okay.
Okay.
Good.
Yeah, the
I-
contact
I-
information for both of us is on the bottom of the invite that we
Right.
had the Zoom link from.
I have
Okay,
to get
thank
going,
Mhm.
and I don't know if you have any questions. Please, you can contact me, and I'll be more than happy through. I think you have my email.
Yeah.
2 emails, and I have to go. Thank you very much for the invitation, and I really
Thank you
enjoy
so much, Dr. Caspo. You were wonderful.
Thank you,
How long-
Doctor.
Yes, thank you.
Thank
Have
you
a
for
good
your
time.
time.
Thank you.
Stay safe. Stay safe.
Thank you so much.
Yeah.
You too.
Bye bye.
Bye bye.
Bye bye.
Bye.